So, Assalamu alaikum, everybody. My name is Aghiad Alkhachem. I'm a second-year medical student, and I'll be helping you better understand control of cardiac output, specifically the latter part of the lecture. Now, before we start, let's just set some ground rules, and it's just simple, all right? If you have any question, please feel free to ask me. Tamam. Please text through the chat. We have certain checkpoints for everybody to unmute and ask their questions and show me their line of thought, all right? This is a learning session, so don't be hesitant to ask any questions, no matter what they are, even if it's how are you? Bismillah, let's start. So continuing what my colleague has started with, right? We will define and discuss examples of active and reactive hyperemia, which is part of autoregulation. We also graphically illustrate the relationship between venous return and right atrial pressure, graphically illustrate the relationship between cardiac output and right atrial pressure, illustrate how cardiac output and venous return can change as a function of right atrial pressure. It might seem like a lot, but don't worry, it's just a graph. And finally, predict how physiological or pathological changes may alter the shape of the cardiac output / venous return curves. Right, you'll know more about these curves at the end. So, Bismillah, hyperemia. What is hyperemia? Right, by definition, it is an increase in blood flow to different tissues of the body. Right, hyper means more. Emia, anything that has to do with emia is the blood, right? So hyperglycemia, hyperemia, anemia, they all have to do with the blood. So hyperemia means increased blood flow. And we have two types of them. The first one being active hyperemia, and the second one being reactive hyperemia. Now, the mechanisms of hyperemia are related to the metabolic changes in the tissues. So accumulation of metabolites induces vasodilation. What that means is basically, right, if the tissue works more, it releases more metabolites because it's like its metabolism is increasing, right? And so these metabolites just signal for the body, right, to give us more blood, to wash out these metabolites, as my colleague has said, right? And so you have two mechanisms of such increase. So active hyperemia, right, is basically an increase in blood flow due to an increase in metabolism. All right, not just metabolites. So metabolites increase due to metabolism, right? And so that signals for more blood to come. And so an example of that would be muscle during exercise, right? So increased blood flow to active muscle during exercise. That's called active hyperemia. So as you can see here, tissue metabolism increases, right? That releases the metabolites and vasodilators, right? For example, potassium. That causes dilation of arterioles, right? And decreases the resistance in the arteries, and blood flow increases, right? And that's the main thing, O2, right? We need more oxygen, right? So the less the oxygen, the more metabolites, it's a signal that the body needs more help, more blood. Is that fine? And so as you can see, metabolic theory causes vasodilation and increased blood flow. Active hyperemia, you see how the chart goes? It's very smooth. As soon as the body needs help by signaling with the metabolites, the blood flow increases. So far, so good? All right, so this is a slide I adapted from Dr. Peter, right? That basically explains the theory, the vasodilator, metabolite theory, or the oxygen demand theory. You don't have to really memorize these names, right? It's not it's not something controversial, but all you need to know is that, right, at the arterioles, you can see here, that's the arteriole, right? There's the precapillary sphincter, and that's the bit, right? Now, usually in skeletal muscle, you don't always get the full blood flow to the skeletal muscles, right? So usually they're closed, as you can see here, right? However, when blood flow increases due to the increase of metabolites or decreased oxygen delivery, right, it doesn't have to be always pathological. Oxygen delivery may be too little for an exercising muscle, but at rest it may be perfect, right? And so the decrease in tissue O2, right, causes relaxation of arterioles and precapillary sphincters, the ones here. And that relaxation increases the perfusion and capillary density. That means more blood is flowing. Tamam? And here is the same idea, basically saying tissue metabolites increase, right? Like, for example, H+, lactate, potassium, right? These all signify that metabolites are accumulating, all right? And that helps for vasodilation, more blood flow. Perfect? As you can see here, blood flow and capillary density, all right, increases. So far, so clear. Please just type in the chat any questions. And this is just to show you active average leg muscles blood flow before and during treadmill exercise at progressively increasing speeds. So we start off here, and the more the muscles work, the more the metabolites accumulate, right? The more the blood flow, as you can see here, right? Is that cool? All right. This is just an example. You don't need to get into the nitty gritty of gracilis or plantaris. It's just to show you that basically the more the tissue works, the more the muscle works, the more the blood flow. Why? Due to increased metabolites. All right. Now, reactive hyperemia, what is it? It may sound the same, right? They're both hyperemia, right? But it's mainly due to a short interruption of blood, right? So it's not necessarily that the muscle is working more per se, but the interruption of blood, right, makes the metabolites in ratio to the amount of blood that there is there, right, too much, right? And so after it finally opens up, right, you see this huge surge of blood, right? And as you can see, our short interruption of blood flow causes vasodilation and increased blood flow. Simple. So tissue flow is decreased due to occlusion, whatever it may be. Maybe even constriction, and you'll know later about this more, you know. And metabolic vasodilators accumulate, right? Dilation of the arterioles, but occlusion prevents blood flow, right? Occlusion, that's the main keyword for reactive hyperemia. Reactive hyperemia means occlusion. There may have been occlusion. It's not necessarily pathological as well, maybe due to contraction of muscles, right? But as soon as the occlusion is removed, right, decreases the resistance and increases the blood flow. All right, can you see that? And then keeps on going until vasodilators are washed away. All right, so it's just this period of occlusion, whatever it may be again, right, that causes this huge surge of blood flow. Is that fine? Right. This is just to show you, the more the occlusion lasts, the longer it lasts, right, the higher the blood flow will be after the occlusion has been opened, right? So 1 minute, 2 minutes, 5 minutes, you can just see here. It's pretty simple, all right? Right. So skeletal muscle blood flow, right? I just want to make sure, is everything clear? Please type yes in the chat. I want everybody to be interactive, please. There are barely any people here anyway. All clear, tamam. Right. So skeletal muscle blood flow. So as you can see, active hyperemia can increase blood flow by as much as 20-fold. All right, if we can go back to the previous slides, all right, Dr. Peter's slides, all right, you can see here, hyperemia can increase the blood flow by up to 20-fold, right? Because when resting, you don't need all these muscles to work. So it would be a waste, right? It's like a faucet. You don't always keep it open. You close it. Whenever you want to wash your hands, you open the faucet. Same thing goes for the precapillary sphincters, right? Once these metabolites accumulate, right, like adenosine, like hydrogen, like potassium, all these metabolites signal that, okay, there is more exercise, there's more effort is being done, right? And this, can you see the capillaries here? How many capillaries are getting opened? Increases the capillary density. You don't need to know much about the capillary density. It's just something we learned last year, right? And this shows how it can increase by up to 20-fold. So at rest, it's like 15 to 20% of blood flow goes to skeletal muscles, according to you, Dr. Simon's slides, right? But when doing vigorous exercise, it can shoot up to 80 to 85%. It shows usually these arteries and arterioles, specifically the arterioles, are under a specific tone, right, to prevent wasting of the blood. All right. So let's just hope everything is clear so far. All right. So in phasic activity, phasic means dynamic, right? Movement, dynamic, right? Such as running, right? Active hyperemia is predominant. Isn't the only reason for the increased blood flow, but it predominates in phasic activity like running, right? Dynamic movements, right? With occlusive muscle activity such as lifting weights. You're not moving, you're lifting weights. Extreme contraction is happening, right? And that's why it causes the occlusion, right? Reactive hyperemia is predominant. Now, both of them affect primarily by adenosine and potassium. These are the primary metabolites that signal we need more blood, help. All right. So let's see the next slide here. All right, that's a checkpoint to make sure everybody's okay. It's very simple in the beginning, right? So everybody, please tell me, is it okay? Do you guys have any questions? All right. So I'll ask you a question of my own. Is that fine? Right. So what causes reactive hyperemia?
Occlusion.
That was somebody. All right, perfect. What metabolites mainly mediate the actions and mechanisms of active hyperemia? All right, perfect. Yes, potassium and adenosine. All right, there are other metabolites as well, right? But these are the main ones we're going to talk about. All right, just to summarize, go quickly because we're going to continue further with this topic. I think everything is clear. You see the slight occlusion here, right? Occlusion causes the dip down in blood flow, right? So even for that small amount of period, the metabolites increase. So as soon as that occlusion is gone, even though you're not, like you may be resting, right? Blood surges to compensate for the accumulation of metabolites. I think everything is clear so far. If you have any questions, please feel free to ask. All right, checkpoint, are you guys okay? All right, so coronary blood flow. All right, so basically it's almost, not entirely, but almost entirely controlled by local factors, and that's due to the lack of alpha-1 receptors, right? There aren't many alpha-1 receptors, right? And if you guys remember correctly, it induces constriction, vasoconstriction, all right? And so the metabolic control for coronary blood flow from the hyperactive hyperemia, right, in systole or systole, right, mainly mediated by adenosine and low oxygen, right? There are two theories. You guys talked about it, and it was in Dr. Peter's slide. And reactive hyperemia due to compression, right? Compression isn't pathological per se, but it's due to the immense contraction. You have to know that the muscle, the heart, at the end of the day, is a muscle, right? It pumps blood, right? So it uses metabolites, and the vessels contract, and the vessels constrict and dilate accordingly. All right, and then you get the myogenic control because it's a muscle, myogenic muscle, right? So you get also a nitric oxide by the shear stress. I think my colleague has stressed about it, shear stress. All right, let's go to the next slide. All right, so left ventricular coronary flow is highest during diastole, right? So basically what happens, the heart is pumping and there's slight sympathetic activation of the heart. So it works more and more, right? Let's just assume you're working out more, all right? That causes increased contraction, right? That increased contraction also constricts the vessels a little bit, right? That constriction, that period of time, the period of constriction, right? It has less blood, and that less blood with the same amount of metabolites signals that we need more blood. And that's why, therefore, during the systole, right, you get more blood, more flow of blood, right? So that's the main effector during systole, is the slight constriction of the arteries during contraction of the heart, right? That gives us a little less blood, more metabolites for the ratio of blood, now more blood flow. All right, now it says here, initial arterial compression during systole decreases left ventricular coronary flow, right? Compression, right? And so during diastole now, right, the constricted or quote unquote occluded artery opened up, right? So during constriction, that's the artery right here, right? During constriction, it's a little small. During contraction, it's constricted, right? Soon as the left ventricle relaxes, a surge of blood comes, right? Because it's relaxed more now. And that is similar to the reactive hyperemia. Reactive hyperemia. Too many lines. Let me just, you guys can read, right? So the main effector during systole, right, is active hyperemia due to the lesser amount of blood. And during diastole, right, it's reactive hyperemia because the muscle relaxes, and you got to understand the ventricles are quite a strong muscle, right? And so they need to pump blood to the whole body. right? And so once they relax, the vessels open up, and that causes for the increased surge of blood. I hope everything is clear so far. Now the myogenic control, right? The shear stress that is put on by the sympathetic innervation. You know, we said it's limited, but it's not absent, right? So due to the sympathetic stimulus, right? The vessels are experiencing more and more stress. That also helps in release of nitric oxide, right? So even though there is some sympathetic innervation that helps vasoconstrict the vessels, the end result is vasodilation, right? And more blood flow due to the accumulation of adenosine, reactive hyperemia, and nitric oxide. And some say it all started by dominant effect of the sympathetic innervation that vasoconstricts the vessels, so it initiates everything more and faster. All right, so let's go to the other slides. Everything so clear so far? Type yes. If you have any questions, please feel free to ask me. I'll repeat. So we've said active hyperemia is when there are too many metabolites. Okay. Reactive hyperemia is when there's a slight occlusion, not necessarily pathological, right? And then opening up of the vessel, right? As you can see in the previous slide. You see the occlusion here, okay? Due to, for example, muscle contraction, right? Strong muscle contractions can constrict the vessels a little bit, right? And then once they relax, a surge of blood comes, all right, to compensate for the metabolites that accumulated during the constriction. Clear? All right. If it's not clear, please tell me. I'll give you some time. Is it clear so far for whoever asked? I'm assuming it's clear because nobody's answering. I don't get how it's in their diet. Okay, all right. So I'll explain diastole and systole again, all right? So during vigorous exercise, the blood needs to pump more, right? And therefore it needs more blood flow because at the end of the day, the heart is a muscle, right? So the heart is pumping more, it needs more blood flow because it's a muscle, all right? So the contractions of the heart can cause constriction of the vessel, mainly at the left ventricles, all right? So we have a couple of mechanisms for coronary blood flow to be maintained even during vigorous exercise. All right, that's coronary blood flow to the heart, even during vigorous exercise. All right. Now it says here that the limited sympathetic control isn't that effective, right, due to the limited amounts of alpha-1 receptors. There are some alpha-1 receptors, they induce some vasoconstriction, right? But the overwhelming effect is by the autoregulation mechanisms of hyperemia, active and reactive, and myogenic control. Is that clear? That's just an introduction. Okay. So you're doing exercise now. We're exercising more. There's stress put on the heart. It's a muscle. Okay. So you get active hyperemia because the metabolites are accumulating, right? Reactive hyperemia due to the constriction that's happening to the vessels by contraction of the ventricular muscle. Right? Imagine that's the heart, it's contracting, all right? And the shear force with which it is contracting, right, constricts the vessels. That's during systole. So the vessels are getting smaller, so the blood flow is less. So the amount of metabolites in the blood, in comparison to the amount of blood that is present, okay, there's a lot of metabolites. So this is active hyperemia. During systole, right, is getting more blood flow due to the accumulation of metabolites, mainly adenosine, as you can see here. All right, and the low amount of oxygen because obviously it's working more. All right. Now, reactive hyperemia mainly happens during diastole. When the ventricles relax, the left ventricles mainly, right, they induce more blood flow by relaxing or quote unquote allowing for dilation of the vessels. Perfect. And so now the arteries that were like this opened up, allowing for more blood, the surge of blood. right? So this is reactive hyperemia. After that compression during systole is removed, right? Or quote unquote occlusion, in this case, if you want to apply both concepts, right? A surge of blood comes in to help compensate for the metabolites and the work that has been done during systole. Perfect. Okay, Tom. Good. And then you get myogenic control because it's working more blood, shear stress on the vessels, releasing nitrous oxide. Okay, perfect. Tom. So again, left ventricular coronary flow highest during diastole, right? Because more blood. All right. Initial arterial compression during systole decreases left ventricular coronary flow, right? Because there's compression. We talked about this. It's systole, right? I think you guys know systole is like a fancy word for contraction. That's what Dr. Abdul Jabbar told us, and diastole is for relaxation, right? Now it says here that the right ventricular coronary flow does not decrease initially during systole as less compression occurs. So the right side is quote unquote weaker. It doesn't have to distribute blood to the whole body, right? It's only for the lungs. So its effect isn't that severe in comparison to the left side of the heart. As you can see here, this is systole or systole, and there's the left coronary, right coronary. Soon as systole ends, as you can see here, in the left coronary arteries, there's a huge surge of blood because of the immense contraction, right? And the vasoconstriction due to the contraction of the heart vessels, right? That happens. So as soon as it relaxes and systole ends, right? There's a huge surge. It isn't as potent or severe in the right side because the contractions aren't that strong. Is that clear? Does everybody understand coronary blood flow? Perfect. I need more people to say yes. All right, I'll repeat. Tamam. I'm just saying, all I'm saying here, right? That we've talked about active and reactive hyperemia. Active hyperemia due to an increase in metabolites. Reactive hyperemia due to occlusion. Is that clear? Occlusion isn't necessarily just closing of the vessels, it's just narrowing down, for example, which is the case of the ventricular contraction. All right. And so soon as that contraction ends, the vessels open up because the heart has relaxed, right, and more blood surges through. Is that clear? Can anybody answer, please? Yes, perfect. I hope you understand. If you have more questions, please don't be afraid to ask. All right, perfect. Now, for the brain isn't a muscle. So what's so different? All right. It's similar in the manner that it's almost controlled entirely by local factors, the autoregulation we've talked about, active and reactive hyperemia, right? And it also has limited sympathetic nervous system control because of the few alpha-1 receptors, right? So you only get metabolic control, right? You don't get the myogenic control that you see here. You only get metabolic control, right? But if you can see here, there's active hyperemia, right? Without reactive hyperemia. And that is because the heart, the brain isn't pumping anything. It's just an organ, right? There is no contraction, all right? But the active hyperemia induces the extreme blood flow due to the accumulation. Why am I not typing? 1 second. All right. Due to the accumulation of CO2. You guys have to understand that the brain is a extremely metabolic organ. All right. It uses up a lot of glucose. Glucose is its main source of energy. So it's a highly metabolic organ, right? It takes around 20% of blood flow, if I'm not mistaken, right? Even though it only weighs around 2 kilograms, it's like only 2% of the body's weight, right? Unlike skeletal muscles, which are 40 to 45% of the body weight. However, they usually get at rest 15 to 20% of blood flow. So this just shows how much metabolically active the brain is. All right. But again, it's not a muscle, so you don't get reactive hyperemia, right? Nor myogenic control. So it's mainly by active hyperemia through the accumulation of carbon dioxide, right? Again, it's a very metabolic organ. Here it just says that the basilar artery and the internal carotids combine to form the circle of Willis, which helps maintain blood flow to the brain. This is the circle of Willis. I got it from Google. All right. And it just shows you we cannot sacrifice any blood flow to the brain. See, it's the most important organ, basically. The brain shuts off, everybody shuts off. Everything shuts off as well. All right. So this just shows you how we cannot sacrifice anything, any blood flow to the heart, to the brain. All right. This is just a picture to show you. I don't think you need to know the anatomy of it. You guys know better. All right. So is everything clear now? Perfect. All right. So hypercapnia, right, means more metabolism happening, right? More metabolic activity, right? More blood flow, right? Hypocapnia, which is basically too little carbon dioxide, right? You're getting lightheaded, right? But that's a totally different situation. You'll know more about in the pulmonary section of this block. All right. So I hope everything is clear. So far, so clear. So far, so good. All right, perfect. Okay, good. All right, so regulation of cardiac output. Okay, we're gonna talk about it. But before we talk about it, let's just a quick checkpoint. Does anybody have any questions? Is everybody okay? Now, this is the third part of the lecture. It's quite a big lecture. All right, this is the third part of it. So I just wanna make sure everybody is doing fine. If I didn't see a question, please unmute now and tell me. I'll give you a minute. 221455. I'm glad you're interactive. I want everybody to be interactive. All right. Even the host, I don't mind. I just want everybody to be interactive. Is it clear?
So far, so good.
Perfect. All right. So the relationship between venous return, this is venous return, and right atrial pressure. All right. So venous return is dependent on the driving pressure, right? Delta P, between the venous system and the right atrium. This is the venous system, right? This is the right atrium, right? In order for blood to go from the venous system to the right atrium, there must be a driving force, right? If the pressure side of the atrium is more than the venous side of the body, right? Blood won't go. It won't go to the atria, nor the heart, and then no blood flow. So you need a difference in pressure, and that's why delta is here, right? To help maintain the blood flow from the veins to the heart, right? Specifically the atrium right now, right? And then to the rest of the body. Okay, so the pressure usually in the atrium is 2 millimeter mercury. All right, and at the end of the venous system, the vena cava, right, it's 10. So the difference of pressure is now 10 minus 2 equals 8 towards the atria. All right, so if a change in pressure, either in the venous side, right, or in the atria, okay, right, atrial pressure, yes, right, can change that flow of blood from the veins to the heart. Okay, is that clear? All right. So when right atrial pressure increases, the driving pressure from the central veins to the right atrium decreases, right? That pressure decreases. Let's say the right atrium is more than 2 now. So let's say it's 4. And the venous return is the venous pressure, the peripheral venous compartment, right, has a pressure of, let's keep it at 10, right? So it would be more correct if we do 10 minus 4, now it equals 6. So now the driving force is via a 6 millimeter mercury pressure. So it's less. So the venous return, the blood that is returned from the venous compartment to the heart, decreases. All right. Now, if the right atrial pressure decreases, the driving pressure from the central veins to the right atrium increases, right? And thus the venous return increases as well. Clear? So instead of it being 2, let's say it's 1. So now the driving pressure is 9. Is that clear? Basic concepts here, they're very important. So I want everybody to say yes. Everybody, not just you. All right, everybody.
Yes.
All right, perfect. Perfect.
Crystal.
Good. Now the vascular function curve. Okay. Now it says here the right atrial pressure is increasing, right? The driving pressure is decreasing because of it, right? And now the venous return is decreasing, and vice versa. You see? Right. Now we want to put it in a curve, right? We want to describe this in a curve. So basically, if you take this curve too literally, you might get it confused, right? What this curve is trying to tell you, right? At a lower atrial pressure or a higher driving force, right? You get more venous return. You see that? It isn't necessary to take it literally. It just means that the lower the atrial pressure or the higher the driving force, the more the venous return. Everything we've talked about previously. Is that clear? Now, I put a question mark here, right, of why this is flattened, right? And that is basically, real quick, just due to the decrease of pressure below zero, the veins start to collapse, right? And that's why you couldn't really push the blood anywhere, right? But that's just for your information, to understand the graph even more, right? So the higher the driving force and driving pressure, the more the venous return, all right? And the more the pressure in the atria, specifically the atrium, increases, right? For a set venous return or amount of blood, no external influences, right? The lesser the venous return. All right, let's say the driving pressure of the vein is 10, but we increased this to 7, 10 minus 7, now it's decreased, right? Or let's say in this case it's 7, right, and it decreased. All right, this is the venous return. This is in the pressure. Don't confuse this with the pressure. It's venous return. All right, so let's assume there is no pressure, there is no driving force, right, in the whole body. This is called mean systemic filling pressure. It is basically if there is no movement of blood and the pressure that is put on the vessels of the blood, arteries and veins, right, it's just the blood volume that that is there, right? So this is called mean systemic filling pressure, right, which is 7 millimeter mercury. Okay, so this is the graph. Is it clear for you guys? Is it clear for you guys?
Yes.
Could you go over quickly just the graph? We'll take more about the graph just right now, but this graph is telling you the right atrial pressure, right? When it increases, right, without the venous pressure increasing, right, the venous return decreases, right? This is the previous slide. We just talked about it. The atrium is pumping, is having higher pressure, right? And the higher the pressure, the lesser the driving force, right? If the venous pressure or the driving pressure of the veins, right, is the same. Now we'll talk more about this. We'll get into the nitty-gritty details, right? But for now, all you need to know that there's a pressure that drives the blood from the veins to the heart. Is that clear? And this graph describes it. All right. So the vascular function curve. 3 parameters will increase venous return and cardiac output. And there are 3 parameters that will decrease venous return and cardiac output. You have to put in mind that venous return is equal to cardiac output, right? Because if there's no blood returning through the veins, there will be no blood being pumped, all right? And that's why it says and cardiac output. Okay, so the parameters that will increase venous return would be an increase in blood volume. That will increase the pressure in the veins as well, right? So now more the venous return increases, obviously, right? Decreased venous compliance, and that means basically that the veins aren't stretching. They're not being compliant to the pressure that is applied to them by the blood, right? And decreased arteriolar resistance, right? And what does that mean? What does arteriolar resistance mean? Now, resistance to the arterial side of the body, right? Let me go back over here. All right. Resistance here. All right. If it increases, that means lesser flow of blood through the capillaries, right? Because lesser blood can flow through that now tighter hole, okay? So now pressure at the arteries will increase, because the blood isn't moving as much due to the increased pressure and more constriction. However, pressure at the veins will decrease because there isn't enough blood going in. As you can see, not much blood going in. All right, does that make sense? It may be a confusing topic. The concept may be, okay, perfect. All right. So if the arterial resistance at the arterioles decreases, that means more blood will flow to the veins. Is that right? It says it here. More blood will flow to the veins if we decrease the arteriolar resistance. Okay. And so again, to rehearse, blood volume, increase in blood volume will increase venous return due to more blood there being in the veins, right? That's going to the atria. That's venous return. Decreased venous compliance, right? The veins aren't stretching as much, all right? And that means that the blood isn't pulling at the veins. So that means more, when you constrict it, more blood will flow to the atria. Is that clear? And then arteriolar resistance. Okay, if we decrease the amount of blood going to the veins in the first place, there won't be much pressure. The driving force will decrease. And if the driving force decreases, the venous return decreases as well. Is that clear? Perfect. Right. So vice versa, three parameters will decrease venous return cardiac output. Okay, that will be a decrease in blood volume, right? The opposite. Increase venous compliance. All right. So as you can see here, blood is complying to the veins are complying to the pressure. So there would be pooling of blood. This is the right atrium. I know I'm a very good drawer. All right. So when the veins are very compliant and not as non-compliant, right, the blood will pool down. So less venous return. Right? And increased arteriolar resistance, right? And I want one of you to explain why increased arteriolar resistance, it's pretty simple, right? Decreases venous return. Can somebody unmute and explain, please?
An increase in arterial resistance would decrease the blood flow. Decrease in blood flow decreases venous return and cardiac output.
Blood flow to the veins, right?
Yes.
And a decreased blood flow to the veins will decrease the pressure in the veins, decreasing the driving
Increase in
force that we talked about.
compliance as well.
Yeah, as well as that. Yeah, good. Right? Perfect. Now we're getting to the nitty-gritty, right? So this is the graph that we've previously talked about, right? See here. Okay. This is just at a normal state. Okay. Now what would happen to that graph if we increase blood volume, right? We increase the blood volume. What would happen to that graph? Well, an increase in blood volume would increase the pressure, right, in the veins, thus increasing the venous return. Does that make sense? It's just the same example in the arteries. Okay. So, and thus a decrease in blood volume will decrease the pressure, will decrease the venous return. Does that make sense? So an increase in blood volume shifts the vascular function curve up and to the right. You see here, up and to the right. So it basically says, right, the blood volume, when it increases, right, you'll get more venous return, okay, for the same amount of atrial pressure. However, that wouldn't be the case, right, as blood in the veins is more effective and more potent in its effect than arteries, blood in the arteries, all right? And thus the right atrial pressure will also change, you see? So the graph goes up and to the right. Is that clear? And it would be the opposite if we decrease the blood. Okay, so one more time. Increasing the amount of blood increases the pressure, increases the venous return, right? Because it's a change in the veins, right? Because the veins accommodate for most of the blood in the body. It accommodates for more blood than the arteries. So that change is also applied to the right atrial pressure, as you can see here. And the graph goes up and to the right. Okay, because the change, right, in blood volume is more potent when it shows in the veins, right? And thus it affects the venous return and the right atrial pressure. So that's why it's parallel, right? So the right atrial pressure increases, but the venous return also increases, okay? And that's because more blood volume is being there, okay? So ways we can increase blood volume, there are myriad of ways, but we can infuse, right? IV saline solution, right? That increases the blood volume, and you'll see that even in emergency cases, right? To infuse saline, right? And then it says vice versa. If we decrease the blood volume, it goes down and to the left. All right. So anything that has to do with blood volume, if I ask you anything about the blood volume, right, you'd expect the venous function curve. This is called the venous function curve, right, to move either up or down, left or right, in a parallel manner. Is that clear? So could we say these have? Let me just open the chat. So could we say these have a direct proportional relationship? Yeah, I guess, yeah, you increase blood volume, so increase venous return, right? And you also increase right atrial pressure. So yeah, I guess a proportional, directly proportional relationship. All right. Now, what would happen if we decrease the venous compliance? Okay, so a decrease in venous compliance, right, means that the blood is moving from the veins, the pooled blood is moving, so the more volume increases, right atrial pressure. Yeah, because blood changes, right, especially the ones affected by like the veins, right, affect the whole body. You'll see why I'm like being specific about this in the next slide. As you can see here, the right atrial pressure isn't changing, right, but the venous return is, and that's why you have to wait for the information of it. All right. But basically, the veins accommodate for most of the blood, or more blood than the arteries, and that's why any change of blood in the veins will affect the right atrium as well. Got it? Because venous return is technically also right atrial pressure, because the blood going from the veins, right, is going to the atria. So the more the blood is going to the atria by the veins, the more the pressure there will be in the atria, right? But because we're increasing blood volume in general, and the example before here, right, there will be a all in all increase in venous return. Got it? Perfect. Okay. So what happens if we decrease the venous compliance? Perfect. We're seeing more IDs replying. I like that. Okay. So a decrease in venous compliance shifts the vascular function curve up and to the right, just like the blood transfusion or increasing blood volume. Right? The changes are similar. Why? Because the blood in the veins, right, is moving to the right atrium, and because the veins are affected and the right atrium is also affected by the change of blood, by the movement of blood, right? The graph goes up in a parallel manner and to the right or to the left. Up and to the right if we decrease venous compliance, constrict the veins, and the blood doesn't move backwards because the veins have valves in them. All right, so it forces the blood towards the right atrium. Okay, and so decreasing the venous compliance or venoconstriction, right, forces the blood to the right atrium, increases right atrial pressure, but more so affects the venous return because more blood is returning. And when venous return increases, cardiac output increases. Okay, is that clear? Perfect. So if you would expect that if we increase the compliance of the blood pressure that is being applied to the veins, pooling will happen, all right? And the venous return would decrease. Got it? So that's also, that also accommodates for the right atrial pressure. Does that make sense? Good. Now, what would happen if we constrict the arteries, or more accurately, the arterioles? All right. Increasing the arteriolar resistance decreases the venous volume because, as we previously mentioned here, Where is it? You see, because when we increase the arteriolar resistance, less blood is flowing through the veins, even though there's more pressure in the arteries, right? The less the blood flows into the veins, the lower the pressure, the lowering the driving force, the lower the driving force, the lesser the venous return. All right. And so let's just get back to the slide.
Again, one more time, please.
All right. Well, I just mentioned here, right, is that once we increase arteriolar resistance, can't zoom in, right? But basically here, right, because the major resistance vessels are the arterioles, right? And so once we constrict them or increase their resistance, right, less blood will be able to flow to the capillaries, and thus, if the less the blood that flows to the capillaries, the less that the blood will reach the veins, right? The less blood in the veins, right? Lesser blood, lesser pressure, right? The lesser the pressure, the lesser the driving force. All right, perfect. And so the lesser the driving force, the lower the venous return, and vice versa. Okay, so let's just go back to the graph. Yep, here it is. So we're increasing arteriolar resistance, decreasing the venous volume, right? Decreasing the driving pressure, decreasing the venous return, right? If we open up these arterioles, right, decrease their resistance / tone, right, there would be more blood going to the veins, increasing the pressure, increasing the venous return. Is that clear?
Yes.
All right, perfect. Now, as arteriolar resistance increases, what happens to the pressure in the arteries? They increase in the arteries, but in the veins, they decrease. And we just explained why. Okay, because at the arteries, it's constricted, so there's more blood for a lesser diameter, but later on downstream, right, there would be lesser blood because the blood can't flow as easily, so therefore the pressure in the veins decreases. So this decreases, this increases. All right, you get it? An increase, but a decrease in the veins. Perfect. So once we decrease the arteriolar resistance or arteriolar tone, all right, the venous return would increase, right? As you can see here, it would increase, right? But that doesn't cause a change in the right atrial pressure. Okay, it just means more blood is going. Khalas. All right. It may be a bit confusing, right? And for what it took for me is just to memorize it like this, right? Because there are nitty-gritty details, because you have to implement the whole system, not just this concept, right? But when we perform arteriolar resistance, right, the graph goes up. The right atrial pressure doesn't change, all right? Because most of the blood, as we previously mentioned, all right, most of the blood, as we previously mentioned, okay, is in the veins. So once we increase the pressure in the arteries, not much change will happen to the right atrium because most of the blood is accommodated in the veins. Got it? Does that make sense? It may be a bit confusing. It took me a while to understand. Don't worry, you guys. Okay, good. Perfect, right? And so once we increase the pressure, the right atrium doesn't get affected, right? But there's less venous return, right? So the graph goes downwards. Right atrial pressure doesn't change, right? There's no parallel shift. So this is because the arteries won't be returning the blood to the right atrium. Yeah, the arteries won't allow much blood to go to the veins, right? Decreasing the venous return, right? And the reason why that doesn't decrease the right atrial pressure is that most of the blood is in the veins, right? And so that doesn't really change the pressure at the atrium, okay? You don't really need to get into the nitty-gritty. You just need to understand, right, that anything that has to do with arteriolar resistance will shift the graph in such a manner. Clear? Up or down. There is no left and right, unlike here.
Will that still affect cardiac output?
Yeah,
Since
the venous return is
the pressure
decreasing.
isn't changing.
Yeah, the venous return is decreasing, right? And that eventually will lead to a lesser cardiac output. But sometimes you need the pressure in the arterioles to help move the blood. If, for example, you have hemorrhage, right, loss of blood, you still need the blood to flow, right? So if the arteries are big, right, the flow would be decreased. But for that same amount of flow, if the arteries were smaller, it would increase. It would be faster. All right. The flow wouldn't increase as in blood flow, but it would be faster because there's more pressure. All right. So in like examples, I think you took it before, in hemorrhage, right? The first thing we do is via renin-angiotensin and whatnot, we constrict the vessel so the blood can flow. Now, is the blood flow more or less? That's not important. For now, we just need the blood to flow. I would rather have little oxygen flowing through the body than all of the oxygen go to a certain part of the body because of the vasodilation, right? And so arteriolar resistance, right, is useful. Don't take it as, oh no, it's just pathological. But it's all you need to know for now, for this graph especially, right, that arteriolar resistance, increase or decrease of it, right, will cause an upwards or a downwards shift in the graph. There is no left and right. Clear? There's a bit of memorization here, but I hope you guys all understood.
No, it's clear. Thank you.
Good. You're welcome. All right. So in summary, changes to the vascular function curve reflect changes in blood volume, right? Increase in blood volume up to the right. Venous compliance, if it decrease, if the veins constrict, right, or are less compliant, more blood is forced to the heart, right? And so up to the right again. Or if arteriolar resistance, right, it's up and down. That's it. There isn't left and right. Okay. So is everybody clear on that? All right, we have a checkpoint now. If anybody has any questions, feel free to unmute. I'll give you 30 seconds. So far, so clear. I'm glad. All right. Okay, let's continue. Now, cardiac function. We talked about venous function, right? Cardiac function, right? As you can see, it's a totally different graph. Okay, it doesn't go from that way, right? It's the opposite. Okay, shifting the cardiac function curve. Changes in contractility shift the cardiac function curve. Increased contractility shifts curve up and to the left, right? And decreased contractility shifts the curve down and to the right. So as you can see here, if the heart is contracting less, right, that means its output would be less, right? And if the heart is contracting more, right, for the same atrial pressure, now the atrial pressure isn't an antagonist, quote unquote, in this situation. Okay, now you know why in a bit, right? But for now, increasing contractility would logically increase cardiac output, right? Decreasing contractility would decrease cardiac output. Get it? So decreased contractility for the same atrial pressure, right, gives us a lesser cardiac output, right? Increased contractility, more cardiac output. Is that clear?
Yes, very clear.
Perfect. All right, so cardiac output must equal venous return, okay? Because as we just said, the blood that is returning to the heart is the same blood that is being distributed by the heart to the body, pumped out of the heart, all right? So there's only one right atrial pressure where cardiac output equals venous return. That's normal point because the graphs aren't parallel, right? So they can't intersect at many points. It's only one point, they cross, all right? So as contractility, blood volume, venous compliance, or arteriolar resistance, these four components, right, and factors are altered, the intersection point of these two lines will change. There's an intersection point, but it'll change. Okay. So this is called the cardiac function curve, and it mainly signifies contractility. Okay, now we'll talk about more about some basic concepts. All right. Shifts of, hold on, let me just, okay, make sure I did not miss anything. All right, perfect. So shifts of the cardiac vascular function curves. A patient is given a blood transfusion. Okay, what curve will be affected? Right, and that will be the venous function curve or venous return curve, this curve. All right, not this, okay, because the blood volume is being affected. All right, and so if we're giving a blood transfusion, by increasing the venous return, increasing everything up, it'll go up and to the right. Is that clear? It's just revision, right? So what direction will the curve shift? Up and to the right. What is the new cardiac output, right? It increases, but the cardiac function didn't change. It's the same. It's just that the blood is receiving, the heart is receiving more blood, so it pumps more blood. Is that clear? I think it.
Quick question. So since the change happening here is through the veins, only the vascular function curve will change, not the cardiac function curve.
Come again, please.
I'm saying since the change happening is through the veins, only the vascular function curve will change, not the cardiac function curve.
Yeah.
Okay.
We'll get more examples of that later on. Okay.
Okay.
I just feel like I didn't give the cardiac function much time, right? But it's very simple. Okay. There's a concept called Frank-Starling. Okay. It basically says, right, venous return equals right atrial pressure, right? Because the more the blood returns to the atrium, the more the pressure will be in the right atrium. And how does the blood return to the right atrium? By, the venous return through the veins, right? Now, right atrial pressure increases the end diastolic volume. So when the blood, that means the higher the right atrial pressure, right? It means more blood is being pumped to the ventricles. So the end diastolic volume, when the ventricles are fully filled, will increase because there's more blood being pumped to the heart, to the ventricles of the heart. Okay, is that clear? And so when there's more blood being pumped to the heart, to accommodate for the greater volume of blood in the ventricles, right? The heart pumps harder to pump that increased amount of blood, right? And that's why it increases, right? It's just a simple mechanism, right? And that's why the previous graph, you see that increasing blood volume, for example, like this, right, would have a higher cardiac output, right? Because the end diastolic volume increases. All right, and if the end diastolic volume increases, the heart will contract harder. It's just a natural mechanism. It's innately built in the blood musculature, right? Because the more the distension, the harder it will contract to accommodate for the higher amount of blood. All right. It should have been here. It may have been written in the notes, but I just explained it for you guys. If you guys have any difficulty with that Frank-Starling mechanism or law, please tell me, right? It just means that the more the end diastolic volume, the harder the heart will pump. And that's why when we increase the volume here, either by increased right atrial pressure or by increased venous rhythm, whatever, right? The cardiac output doesn't change, but it increases, right? The graph doesn't change, but there will be more cardiac output, right? Because there's the end diastolic volume increases. You got it? Perfect. All right.
Actually, one more time, please.
Yeah. All right. So basically, I'm saying the more blood there is in the ventricles, right? The harder it will contract to accommodate for the greater blood volume, right?
Yeah,
and thus the greater the cardiac output, right? And that's why if you see here, okay, when we increase the blood volume, right, the graph of the cardiac function doesn't change. Contractility didn't change, right? We didn't do any extra stuff. right? Pressure doesn't change and whatever. All we did is we increased the end diastolic volume so that the ejection fraction will still be the same, but the ejection fraction of a greater end diastolic volume, right, will cause for a greater cardiac output because there's more blood in the heart, right? All clear? Okay, perfect. Right? So for the next point now, a patient is given a positively inotropic drug, right? It means increased contractility, right? What curve will be affected? It will be the cardiac function, right? Because it signifies contractility. The harder the blood pumps for the same amount of volume, right, the greater the cardiac output. Does that make sense? Okay, perfect. As you can see, so what curve will be affected will be the cardiac function curve. Okay, what direction will the curve shift? It'll be up and to the left. Okay. No, if we only affect the contractility of the heart, the cardiac function will change only, right? The vascular function curve doesn't change, right? Okay, perfect. Because it's the same amount of volume, same amount of whatever. It's just the ejection fraction increases, right? Because the heart is pumping more contractility, and we have drugs to increase the contractility, right, of the heart. We'll discuss them later with the questions, right? So what curve will be affected? It'll be the cardiac function curve. All right. What direction will the curve shift? Because it's positively inotropic, it contracts more, right? So it shifts up and to the left, right? So the venous/vascular function doesn't change, right? There is no shift in that curve, right? Only the cardiac function curve changes. So now the equilibrium is set at a new point. See that? This doesn't move, only this. Is that clear? If it's only contractility. Got it, you guys? I'm assuming everybody has got it, right? Because we're gonna get questions. Okay, perfect. Done. So what happens if sympathetic nervous system activity to the veins only is increased? Veins only. So no cardiac function, only veins, right? So this is the normal point. We're starting here, right? And only the veins have changed. So since the vascular function curve we'll expect the vascular function curve to change only, right? So we can eliminate all of these, you see, because these are changes of the cardiac function, and we'll eliminate venoconstrict. Yeah, the veins can decrease their compliance, right, and thus, venoconstriction, not vaso-veno. Yeah, more blood flow to the heart. Yeah, because that blood that is pulled is being pushed to the heart. Yeah, we'll answer it now. I'll answer that in front of you guys because we have more questions, right? And because it's only the vascular function that changed, because again, venoconstriction or decreased compliance, as we previously mentioned, the four, all right, blood volume, right, venous compliance, all right, arteriolar resistance, and contractility of the heart, Okay, these four components can change this graph, okay? All right. So now, right, we just said the sympathetic nervous system activity to the veins only is increased. That means constriction. Is that clear? So constriction of the veins pumps the blood to the atria, right? And so we did not talk about any changes in cardiac function. No contractility is affected. So we can eliminate everything from here. There isn't any contractility, okay? Contractility isn't affected. So the cardiac function curve that goes like this isn't affected. Is that clear?
Yes.
Perfect. All right. So we eliminate all these. So we're left, right, with these two. Okay. Now a way to eliminate these two after eliminating everything. Would you expect the venous return to increase or decrease if we increase sympathetic activity to the veins only? Increase, yeah.
Increase.
So we eliminate these, yeah. We eliminate these as well. It's not decreased. All right. So we're left with G and F. Right. I want you guys to figure it out. What is it, G or F? G or F, think. Yes, it's F. Because as you can see here, G has a different curve. You see? And we did not mention anything about arteriolar resistance, right? Since we did not mention anything about arteriolar resistance, then G should be incorrect. Does that make sense? So the graph would shift from this star to F, as you can see here, because even the right atrial pressure, when increasing the venous return, will change. So it goes to the right. So it's it would go up and to the right, as you can see here, up and to the right, F. Is that clear?
Yeah, just to recap, when venous pressure is, venous pressure is, like when asked about venous pressure, right atrial pressure would remain constant? Or was it venous resistance?
No. I'll go back. All right. Right here. All right. We said blood volume is increased in the veins. All right. Can you guys hear me?
Yeah, no, I meant where we have right atrial pressure, like we have no change in right atrial pressure. That was for which one?
For arteriolar resistance.
Okay.
As you can see here. So arteriolar resistance doesn't change the right atrial pressure because most of the blood is accommodated in the veins. So a change in the arteries doesn't really cause for a change in the atria.
Yep, clear.
Got it?
Yeah.
Perfect. However, a change in the veins, venous return will increase their atrial pressure as well. So that's why it goes left and right whenever you venoconstrict or decrease venous compliance, right? Or increase the blood volume, increasing the venous return, increasing the right atrial pressure. If arteriolar resistance is increased, right, not much blood is found in comparison, obviously, in the arteries when you compare it to the veins. So the right atrial pressure doesn't really change. All right. So the change would be up or down, as you can see here in the previous graph. All right. So now if we go back to this slide, right, the star, we said what happens if increased sympathetic nervous system activity to the veins only. Veins only, right? So it's going to go right, left, up, down. It's increased activity, so that means venoconstriction, right, or decreased compliance, okay? And the decreased compliance will cause for a surge of blood to go to the atria, push it to the atria, right? Increasing venous return, right? With a change in atrial pressure as well, as we previously mentioned, right? So left, right, up and down, right? There's no change in cardiac function. So all of these are wrong, right? Because the cardiac function is changing, as you can see here, right? So we pick one from the normal cardiac function, right? And the normal cardiac function one, as we expect the venous return to increase, we eliminate these two, right? We eliminate G because there is no difference in arteriolar resistance. So we eliminate G, so we're left with F. All right, we'll go to the other one. I'll do it myself because we have questions on it. If you guys have any questions, feel free to ask me, right? So what happens if the sympathetic nervous system activity to the arterioles is decreased, right? Decreased sympathetic nervous system activity to the arterioles, right? So since we know it's the arterioles, we're expecting it to be one of these graphs. Okay, so one of these graphs, we eliminate anything from here and anything from here. Okay, there is no change in venous return, but either by blood volume or venous compression, right? Yes, perfect. G. See how the graph? Yeah. Decrease sympathetic nervous system activity to the arterioles, right? That means dilation, more blood is flowing, right? So it's G. Is it clear, everyone? Alhamdulillah. And for the last one, what happens if digitalis is administered? Right, so digitalis, a hint, is a positive inotropic drug. Contractility increases. Perfect. So where would you expect the graph to be? Let me tell you. Okay. Yes, increased cardiac output. Perfect. Yeah. So it won't be this because increased cardiac output, right? Won't be any of these, obviously, right? No change left and right. So this is wrong, right? This is wrong as well because there's no arteriolar resistance. So the change is mainly in the cardiac function because now there's increased cardiac contractility, right? So that means there's more cardiac output. More cardiac output, we eliminate all of these, okay? Everything down is eliminated, okay? We said there is no change in the vascular function, so we eliminate A, F, B, G, because there are changes in vascular functions. And there is no change in vascular function. We're just contracting the heart more, right? It's only cardiac function that is increasing cardiac output, right? And so we're only left with C, because it's the only one that accommodates for a change in cardiac contractility, but no change in vascular function, neither in arterial resistance, venous resistance, or compliance, or blood volume. Is that clear? I want everybody to type yes, because we're gonna ask questions now.
Perfect.
Alhamdulillah. All right. So now this is a summary, a quick recap, right? It's a very good one. I took it from my friend Aghiad. All right. And it basically says cardiac function increases, right? When there's increased inotropy or decreased inotropy. All right. But the vascular function curve is still the same. Okay. And here, the vascular function curve changes if we increase the volume, all right, or venous tone. So that means decrease venous compliance. So when we decrease the venous compliance, the venous tone increases, right? Shifts right and up, right? Or if we increase the volume, shifts right and up, right? Or vice versa, down. As you can see, inotropy is affected by catecholamines. I don't know how you pronounce this drug, digoxin. I hope I did not botch that name. Or decreases, right? Catecholamines and digoxin increase inotropy, right? Or when it comes to heart failure, for example, it is decreased inotropy. The heart isn't pumping, right? So decreased for uncompensated heart failure, right? You get a decreased contractility. So it moves the cardiac function curve down. All right. Now for venous return, we just talked about it. Fluid infusion, like blood transfusion, or increase in blood volume. All right. Or sympathetic activity to the veins, decreasing venous compliance, pushing blood towards the atria. Right. Now the opposite would be true when there's acute hemorrhage, right, or spinal anesthesia. Don't care about the spinal anesthesia now. So acute hemorrhage, there's blood loss, right? When we're losing blood, there isn't much venous return, so goes down and to the left. For vascular function curve, nothing to do with the cardiac function, vascular function. Okay, the contractility is still the same. Why would you change the cardiac function curve? All right, and this is for the resistance, arteriolar resistance. It goes either up or down. Okay, as you can see here. Okay, no change in right atrial pressure, as you can see here. Same. Okay, just up or down, right? Vasopressors, exercise, they all change that. Okay. So this is the summary, right? Checkpoint. I want everybody to relax, right? Collect their thoughts. If you have any questions, feel free to ask me because we're gonna ask questions now. Okay. All clear. I want 2 more people to answer all clear. Perfect. Alhamdulillah.
All
One
good.
more. Alhamdulillah. All right. Now for questions. Let's test your knowledge here. Let's see if I did a good job. Okay. All right, question. Which scenario would result in a shift in the cardiac function curve from point A, right, to point B? What do you think is the answer is? I want everybody to answer. What do you think the change will be? What would cause this change from A to B? B, possibly, B. Yes, I'm proud of you guys. Yes, administering digitalis. Because we're changing cardiac contractility. Exactly. Cause contractility increased. Yes. So nothing has to do with beta blockers, nor heart failure, because it's increasing contractility. So this would be wrong. All right. There is no change from left to right. Right. So that would be wrong. And ischemia, right, and heart failure, for example, or myocardial infarction, sorry, right, decreases the contractility of the heart, right? So that would cause it to go down. But this wasn't the case, right? It increased, and that was because of administering digitalis. Okay. Now the next question. Which scenario would result in a shift in the cardiac function curve from point A to point B, to point A2, sorry. A to A2. All right, so one person said C. I want 2 more people to answer at least. So what would move the curve, right, up and to the right? Come on, more people. I want more people to answer, please. So one person said C. What do you guys say? What science?
C.
Basically like blood, right? So we're getting more. I'm very proud of you guys. Yes, IV fluid. So infusing blood. So C. All right, I'm very proud of you guys. That is correct. I thought you guys would get it wrong, Salaha, because I got it wrong myself the first time. Yes, infusion of normal saline, right? Don't get confused. Not because the vascular function isn't shown, doesn't mean that the graph would be incorrect, that would be no changes, no, right? Because the cardiac function is still the same. Let me see, because you just said it would only move to the right. Yes, right. So cardiac function is still the same. So this and this and this would be wrong, right? Right, because we're moving from here to here. Cardiac function would be the same, no change, right? So nothing has to do with heart failure, right? This is heart failure, right? Nothing has to do with administering digitalis, right? Because cardiac function didn't change, right? We're still on the same line, right? Nothing has to do with this ischemia. So it is infusion of normal saline. Correct. I'm very proud of you guys, because if you see, that's the normal point. We're still on the same curve. We would just go up instead of going from here, right? Still the same cardiac function, no change. All right. And for the last question, which scenario would result in a shift in the cardiac function curve from point A to point C? Yeah, let's see. Think about it, take your time, right? From point A to point C. What does that affect?
B.
Okay, one person says B. What do you guys say? Okay, another person says B. I'm very proud of you guys. I'm very proud. Oh, stop. I'm very proud. Yes, it is correct. That is B, heart failure. Okay, and that is because of decreased contractility. You see, the contractility has changed, right? So administering digitalis would change contractility, but up. Okay, so that's why administering digitalis would be wrong, right? It's the opposite of the first question. Yes, exactly. Exercise would also be wrong, right? Because exercise will, increase contractility, right? And you get more resistance. It'll be totally different graph, okay? And not administering beta agonists is also, and neither is it infusion of normal saline. It's heart failure because it's going down. All right. I hope everything is clear, you guys. If you have any questions, feel free to ask me now. if you go through the slides again of Dr. Simon, I appreciate it. Thank you. And you have any question, if I have missed anything, please feel free to contact me, right? My email number, you can call me whenever, please. All right. I'm just a medical student like you. All right. Yeah. Do you guys have any questions?
Yes, I have a quick question.
Yes.
Beta agonists, how would they affect I would assume they would affect the cardiac function, but how? Is it the same as positive inotropy?
Well, I don't really know exactly for sure because I forgot what beta agonists do exactly. I'm sorry for that. Very bad memory. I think my colleague has explained it, the effects of beta agonists. All right.
Was it the PAL session just before this one?
Yeah. Yeah.
Okay.
He explained what beta agonists do exactly. If I give you a question now, it would be not the most accurate. All right. But I think you get it. If beta agonists would affect contractility, it affect the cardiac function curve. All right.
Yeah.
And if they affect the veins by constriction or relaxation, dilation, right, would affect the vascular function curve. Right. If they affect the arteries and arterioles, they would affect the vascular function, but up and down. There is no movement to the right or to the left. Right. As long as you have these concepts understood, okay. Whenever you read the question, don't be too quick to answer, right? Sit down and think, all right, what does this affect? And how would this be translated in the graph, right? And at the end of the day, it's all about understanding. It's not just memorization, all right? And so if you have any questions, feel free to ask, please.
Thank you so much. This was really helpful.
I appreciate it. Again, please contact me anytime. And yeah, thank you.